In the hospital, when someone has a fever, what you'll see the team do is pull the trigger on infection. We often associate fever with infection. And because we don't want to miss an infection, we generally get everything at once. If fever, chest x-ray, urinalysis, urine culture, and blood culture. But in the post-operative period, you can use the timing of the fever relative to the surgery to guess what the most likely diagnosis is. As we go through this lesson, what I want you to realize is on the test, they're going to want you to pick the right test for the right day. In life, I want you to learn what you can do in the post-operative period to prevent these complications we're going to talk about. You're going to hear all the time on surgery, post-op fever, the W's. Wind, water, walking, wound, and because drugs can do whatever they want, you've got wonder drugs on either side of the typical W's to remind you that at any time a fever might be a drug. So we're going to use this framework to talk about when the fever occurs, correlating to what the most likely diagnosis is going to be, how you're going to make that diagnosis, and also how you're going to treat it, and what you could have done in order to prophylax against it. If someone has a fever during the surgery, it is almost impossible that they had an infection, produce inflammatory mediators, cause a fever. So, the diagnosis is more likely to be malignant hyperthermia. And this is the first W, wonder drugs. If you suspect malignant hyperthermia because the person has a very high spiking fever after receiving anesthesia, you don't have time to make the diagnosis. You're going to give them high flow oxygen, dantrolene to uncouple the fever mechanism, and then cool them off with IV fluids and IV cooling blankets. And there's not really a way to prophylax against this except to ask if they've had a personal or a family history of a bad reaction to anesthesia, which is why you ask that question in preoperative evaluation. You want to know what's the risk of having a bad reaction to the anesthesia. But if someone has a fever right after surgery, right, they're being rolled to recovery, fever, well, then probably the surgeon screwed up. This is going to be bacteremia. And this is particularly dangerous when you have gut surgery, especially when you're taking out something that's inflamed. You accidentally poke the wrong thing, stool leaks out. If you've got a dead, necrotic, infected looking organ you're pulling out, you might leave some behind, or you might translocate it into the bloodstream. If you have bacteremia, you're going to make that diagnosis with a blood culture. And the treatment is going to be with antibiotics. But here you're going to go broad spectrum because you have no idea what bug it was. And generally what you'll see done in the hospital is vancomycin and pip/tazo. To prophylax against this, be better. Maintain your sterile field. And be careful when you go mucking around in the gut that you don't accidentally cause unnecessary bleeding, and make sure you don't poke the bowel. Now we get into our other W's now. So if someone goes through the surgery and does fine, on post-op day number 1 develops a fever, that's probably not an infection. It is the first W, wind, but it's a product of atelectasis. Now you're going to make sure it's not the other complication of the lung, which is pneumonia, by getting a chest x-ray, and it will be negative. Well, at least it'll show you only atelectasis, there won't be that consolidation. And because it's only atelectasis, you don't need to do anything to treat it. Prophylax against it by using inhaled incentive spirometry and get the patient out of bed. You'll realize in this lesson, getting people to move and breathe goes a long way in preventing these complications. But let's say you didn't put them on an incentive spirometer and you didn't get them out of bed and they develop a fever on day number 2. Still in the wind W, reminding us of the lungs, and that is the most likely diagnosis is pneumonia. Fever, cough, and then a consolidation on chest x-ray, you've got a pneumonia. And because it's been 48 hours since they came into the building, into the hospital, this is a HAP, and you have to treat with broad spectrum antibiotics. What you'll see in the wards is vancomycin and pip/tazo. And you could have prophylaxed against this, incentive spirometry, and out of bed. And remember, this person was on a ventilator, they've been in the hospital, they're exposed to very virulent organisms, so you can't mess around with this pneumonia. Broad spectrum. Once you get to post-op day 3, you're into the next W, which is water. That reminds us the person could get a UTI. And urinary tract infections are going to be diagnosed on urinalysis and confirmed by urine culture. The treatment here is going to be antibiotics focused at urinary tract infections. And if you see casts, white blood cell casts, that's pyelonephritis. And chances are they had that infection already prior to going to surgery. It's really weird for someone to get pyelo as a product of a post-op complication. So you get the white cells on urinalysis, you give them antibiotics, and what you should have done is taken the Foley out. Foleys are funny things. They're necessary for long procedures. You have to drain the bladder, and while the person's anesthetized, they may not be able to do that on their own or control it. But when they come out, Foleys are really convenient for the nursing staff. It's easy to measure ins and outs. They don't have to help the patient to the bathroom or the commode. It's convenient for the patient. They just lay there and pee. They don't have to get up and go to the commode. But as we've learned, getting out of bed is good. So get the Foleys out, because if you don't, there's an incentive to stay in bed, causing these other complications. And worse, Foley catheters are made of plastic. And what grows on plastic? Bacteria. So prevent catheter-associated infections by getting the Foleys out as soon as you can. Post-op day 5, the next W, walking. Remind you of the DVT. DVT-PE. The person who is post-op is at the highest risk for DVT. They've just had a surgery, which makes them hypercoagulable, and they're laying around in bed not doing anything, which makes them immobile. Those patients are at highest risk for DVT, and the ones that are at even highest risk, orthopedic surgeries. So if you have a patient who's had a surgery and you don't prevent this, they're likely to get one. The way you're going to spot this is the DVT is going to have a circumference 2 centimeters bigger than one leg to the other. It may present with the PE, which will be hypoxemia and hypercapnic respiratory alkalosis. Check out the next video, don't worry about it. But if you're suspecting the DVT, what you can do is an ultrasound of the bilateral lower extremities. And if you find it, you will treat it with a heparin to warfarin bridge. Remembering that you must bridge when initiating warfarin because they become hypercoagulable in the very early stages. Now this is tricky because it used to be heparin drip to warfarin, but now you've got options involving low molecular weight heparin, subcutaneous injections, and the novel oral anticoagulants. So you have to play with this a little bit, but on the test, it's going to be heparin bridge warfarin because they want you to know that you need the bridge in there to prevent hypercoagulability. And to prophylax against this, not surprising, if you just got them up and walking around, they wouldn't develop a DVT. But where you want to go is low molecular weight heparin. And you might think, wait a minute, heparin, they're going to surgery. Aren't they going to bleed? And appropriately so, we often hold low molecular weight heparin, the prophylactic dose against DVT-PE, the morning of surgery. But as soon as they come back, once they're closed, the risk of bleeding really isn't there, but the risk of DVT is high. So get them on the prophylactic dose of low molecular weight heparin once they come back from surgery. We're getting even further out. Post-op day 7, we're into our next W. That next W is going to be the wound. And at about a week, what you're looking at is cellulitis. Right? They're going to come back. The wound is probably not going to be held together really well. They're going to be erythematous. It might even be boggy. There might be purulent drainage. What you're going to do is get an ultrasound. And that ultrasound is going to be negative for an abscess. You say, okay, it's just a wound infection, no big deal. This is cellulitis. Let's treat it with antibiotics for cellulitis. The way you prevent this is by keeping a sterile field and keeping the patient clean post-op. And this is where patients really screw it up, right? Once they go home, if they're not taking good care of their dressing, they can get infected. Skin's broken down, you cut them open. So do your job in the operating room and then make sure they keep a clean, sterile environment around the wound once they go home. But this W is really where it's going to get you, is 2 weeks out. This is post-op day 10 to 14. This is the person who's left the hospital after recovery and is coming back in for their post-op visit. This W wound is not going to be a cellulitis. It's going to be more sinister than that. That's an abscess. And you may not even think that this fever has anything to do with the surgery. After all, it's 2 weeks later. You haven't seen him in a couple of days because they went home. Well, get the ultrasound, and it's going to be positive for an abscess. By the way, instead of an ultrasound here, you can use a CT scan. If you find that there is an abscess, you're of course going to treat them with antibiotics. But this person needs to go back to the operating room for an incision and drainage. Same thing though, keep the wound clean, won't be a problem. All right, so in this lecture we talked about the 5 W's. Wind, water, walking, wound, and wonder drugs. To remind you, and in that order, wind, atelectasis and pneumonia, water, UTI, walking, DVT, wound, cellulitis, and abscess, is how they're going to present with a fever post-op. Also keeping in mind that drugs can do it whenever they want, but the one you want to look out for is malignant hyperthermia because of its use of dantrolene, making it a great test question, and then bacteremia if someone screwed up the surgery. What you want to take away for the boards is post-op day to diagnostic test. What you want to take away from the wards is how do you prevent these things, which is becoming a hot topic in hospital medicine. That's post-op fever.